Good afternoon, everyone. Now that we've established quorum, I'd like to call today's meeting to order.
Good afternoon, everyone. Today is Wednesday, May 17, 2023, and this is a regular meeting of the Board of Trustees for the County of El Paso's Risk Pool Board. This meeting will also be accessible via Microsoft Teams and via YouTube for the public. The time is 1:03 p.m. We currently have Trustee Asensio not present right now. Trustee Hurtado is present. Trustee Van Hoove is present, and Vice Chair Salcido are physically present. Chair Quilty is absent. Vice Chair Salcido, we currently do not have anyone signed up to address the board.
Thank you. Being that there is no public comment, can you please proceed to call the consent agenda?
Consent agenda. The consent agenda consists of items number 2 through number 6. Does any member of the board wish to remove an item from the consent agenda to discuss in more detail? Does any member of the audience or staff wish to remove an item from the consent agenda?
Do we have a motion to accept the consent agenda?
Motion. Second.
Trustee Asensio is absent. Trustee Van Hoove?
Yes.
Trustee Hurtado?
Aye.
Vice Chair Salcido?
Aye.
Chair Quilty is absent. Motion carries. Regular agenda, item number 7, discuss and take appropriate action on the Aetna Pharmacy Medical and Clinical End of the Year Report for 2022.
Thank you, Claudia. Vice Chair and members of the board, today we have our Aetna team. We have a few of them here in person, and we have one individual online who will be presenting the end of the year review for the county's medical plan. We do have one member who's running late, so we'll go ahead and get started with the pharmacy section first, where Brandon will present that portion.
I think it's the other one.
Adam is sharing. Adam, can you share?
There it is. Yep. Okay, great. So first of all, thank you for your time today. Very happy to be here again. We have asked to keep this somewhat abbreviated, so we're not going to run through the entire deck. However, if you've seen something prior to this meeting that you wanted to cover specifically, we can absolutely jump to that. But the plan for right now is to walk through our executive summary and then pass it to our clinical advisor, Alex Toman, who is on the call, to talk about a new strategy that we have just very recently developed in light of the increase in utilization that we've seen for the anti-diabetic drug Ozempic, specifically for weight loss applications outside of the label usage. So if that's amenable to everyone, we can go ahead and jump in to slide number, I believe it's 4. Yes. Perfect. So a couple of things here. I got a little ahead of myself in the trend category. So I want to clarify, your total gross cost is up 13%. Your gross cost per member per month after rebates is up 3.2%. So I kind of mislabeled that a little bit. So both of those are kind of true at the same time. Net of rebates, you are at a 0% trend. So we were exactly in the same spot at the end of last year as we were at the end of 2021. So the rebates and the programming that we put in place did their job very well. You can see that we saw increases in our specialty gross cost per member per month, up 22%. So the PrudentRx program helped us save well over $250,000 within that realm. And so even accounting for that 22% increase in specialty costs, we saw virtually no trend for the plan. So programming in place is doing its job very well. The rebates as well, as we can see, paid through the third quarter. So we'll see a little bit more mitigation on these numbers when we get fourth quarter rebates paid out here shortly. Just over $2 million in mitigated costs through rebates. So again, we're doing very well. We were very lean comparatively to both our employer book of business as well as our peer group, which is other government entities. So like demographics being compared to there. And when we look at our key cost drivers, you can see that our population is very top heavy when it comes to spend. The top 39% of our membership is accounting for virtually all of our cost. And even within that, the very tip top of that little pyramid is accounting for most of that portion and all of our specialty costs. So when we talk about the strategies and when we talked about Prudent RX and who this was impacting, we spend a lot of time in our clinical oversight in that very top of the pyramid so that we can reach those who are spending the most on the plan, those that are being treated for the most acute therapies. And when we looked at your demographics overall, so the good thing was that we saw a slight increase, but nothing that's really going to throw our per member per month numbers way out of whack, as well as a very slight increase overall as to the percentage of our membership that is utilizing the plan. So we had more members come onto the plan. We had a slight increase in those that were utilizing the plan that were both here before and new as well. So that goes a little bit into the increase in costs that we saw, as well as one more specialty utilizer, but very telling here, 63 more specialty prescriptions in 2022 than we saw in 2021. So even with that negligible movement in membership, especially within the specialty category, we only had one more utilizer and 63 more prescriptions in 2022. So the membership that was here already is now utilizing more within that specialty realm. But the good news is Prudent RX was already in place and again helping us save the better part of $250,000 in that spend, whilst providing access to those specialty meds for $0. So always good to point that out, that these members are being treated for $0 out of pocket on their spend. So when we look at the program set up currently and what is in place, we are on the Aetna standard formulary, which on the spectrum of formulary strategies we have is a little bit more open comparatively. It's got more brands available. We have Pharmacy Advisor, which is a clinical oversight program that helps reach pharmacists and helps close gaps and other clinical outcomes at the point of sale at the pharmacy. So it captures the member right then and there. We've got Retail 90, which allows our membership to get 90-day prescriptions at retail pharmacies. They don't have to go through mail order. We've got our Specialty Performance Network on First Fill, so that's CVS exclusive. If you'll recall, that was part of the move when we implemented Prudent RX, that we moved to CVS exclusive so that we could control that line of adjudication and ensure that it works correctly and we're controlling costs as much as we can. And again, mentioned Prudent RX and True Accumulation there, as well as Choose Generics. Quick reminder on that, that is a program in which if there is a generic available, that the member will be required to fill it outside of medical necessity, of course. But if they do choose the brand, they're not only paying the brand copay, but the cost differential between the brand and the generic as well. Again, assuming clinical efficacy between those two drugs, we're choosing the generics, we're pushing towards generics. So,
excuse me, I have one question.
yes, absolutely.
So what happens if the doctor wants the brand, that generic?
So there's kind of two ways that we look at this. It's we call them dispense as written, or you may say it as DAW, number one, and number two. Number one is prescriber. So it's basically from the prescriber on the prescription. Number two is if the member gets to the pharmacy and says, I want the brand. At the pharmacy, if the doctor says, write this as a brand prescription, the pharmacist can offer a generic alternative. That's their area of expertise, so they will know and which generic alternative will align to the brand written by the prescriber. If the member has an adverse reaction, or as we mentioned, the medical necessity part of dispensing a generic, there are instances where we can bypass that so that they're not penalized for having to take that drug, but that is very rare. So really just driving more towards, as a strategy, the generics specifically, but the pharmacist can help switch that out at the point of sale without the member being penalized unknowingly and have to go back and have to correct that.
Okay, so that way I understand is I go in, I have Humira, let's say, and the pharmacist says, no, I have a generic. And I said, no, I need Humira. So you're going to penalize me because I want the brand, and I'm going to have to pay that extra out of cost.
So assuming that you just want the brand because you want the brand.
Well, it's better.
Well, so I guess that's where we get into the conversation of the clinical equivalency of the generic and the brand. It is a very finite portion of that population that do not respond to the generic, where they do the brand. That's where the medical override comes in to say, we can't treat with the generic, we have to treat with the brand. At that point, we would no longer be utilizing that penalty for the brand instead of the generic.
Okay, so then can you monitor that and see how many of the employees actually stay with the brand and are penalized? So that way we compare it to next year, because I see a lot of that and the employees are just not happy because you're allowing someone else to dictate what's the better prescription and not listening to the patient and or their doctor. So that would be something that the employees would be probably saying, no, I'm not going to do that.
Yeah.
And I have to pay all this money.
Yeah, I will absolutely take that as a follow-up to see how many that we're seeing run into the DAW 1 and 2. So with that, we also have Hello Heart, which we just implemented on May 1st. So brand new, we're 2 weeks into it. So not a lot of follow-up on that quite yet. But we will have more information on enrollment statistics and feedback from the members specifically. So far, so good. I will say anecdotally, another employer that had implemented this on January 1st had an anticipated enrollment about 10% of their target population, and they enrolled close to 30% in the first month. So there was a member desire for this type of program, so I anticipate something along those lines for the county as well. Again, we don't quite know what those enrollment statistics are yet, but we will have those out to you probably within the next 4 to 6 weeks from the Hello Heart team specifically. And then kind of getting into our opportunities, which again, we can cover very briefly, a little bit more in depth, probably more as a follow-up, because I want to have our clinical advisor talk about this new smart edit. But Maintenance Choice is the mail order program that would force members to a CVS, either mail order or CVS location for their 90-day prescriptions, based upon the opportunity that we've seen. There's some room for savings there, but it would be some member impact as well. So that would be a more in-depth conversation that I feel that we have time for today, especially with the clinical and trying to make sure that everyone has their own time. Drug savings review is a retroactive claims review of our claims, and saying that if there's a member on drug A, we've identified drug B that is a clinical equivalent. We then offer that suggestion to make that change to drug B to the prescriber directly. And if they agree, they can change the prescription. And then the savings that we would recognize is the cost differential between those two drugs going on into perpetuity, assuming that they stay on drug B instead of drug A. That is non-compulsory, and typically the member won't even know that interaction has happened. It'll look like the prescriber is making that change. And again, it goes through the prescriber first. And there's no penalty for not taking the recommendation. It's just in line with us saying we're trying to help save the plan money while still providing access to the drug that the member needs to treat that condition.
Okay, so plan A, they can still stay with it?
And typically the member won't even know that interaction or that proposal has been sent, since it goes directly to the prescriber, and unless the prescriber says anything about it, they can dismiss it, and that's it.
Oh, well, I'm not too comfortable with that. And I believe in sharing. So if I go to my doctor, I would appreciate it if my doctor told me.
Yeah, they're not required to keep that a secret. Yeah. It's just more of, hey, I got an email that says drug B is less expensive, and I agree with the clinical, or like, I don't like it, I haven't seen the outcome that I have previously, whatever the case may be. At that point, the prescriber, gets to make the clinical determination. And there's no, you better do it, or we're going to penalize you, or, whatever the case may be. Most prescribers at this point, I think, are well aware of this type of program. More so, we utilize our clinical oversight and insight to provide that as a tool to the prescriber to, again, help, make more efficient the use of our dollars that we have. And then the advanced control formulary, so that would be on a broader drug coverage level. When we talked about the Aetna standard plan, it would condense slightly to more generics, fewer brands. And again, not closing off any access to any of the therapeutic categories that currently exist today. Again, driving towards those generics, lowest net cost within that strategy. The trade-off here is that we would see lower overall drug spend, even net of the fewer rebates that we would realize for the fewer brands that were being filled. And then last is drug exclusion plan design. So, candidly, this is on here as an opportunity to let you know that we are always going to provide you with every opportunity that we have available. However, there's not necessarily a recommendation for this program as it stands right now. We've got some information at the very end of this deck in the appendix so that you can review if you'd like. But again, this is more so for us just to show you that we are constantly monitoring to make sure that we bring to you every option available to monitor and administer this plan. So with that, Alex, can you hear me?
Yep, I'm here. I can hear you loud and clear.
Perfect.
Can you hear me?
Yes, we can. Thank you. So Alex Toman is our clinical advisor. He is going to go through a what we are now calling a smart edit regarding the use of the anti-diabetic drug Ozempic for weight loss that we've seen not just on our plan for everybody. So Ozempic, for a point of reference, Ozempic is now the #2 drug in our entire book of business by total cost. And before that, I think it was outside of the top 10. So this has been extremely rapid development, and just in the last month, we have developed this clinical criteria to kind of align with making sure that it's on label while still providing access to it for those that need it. As you can probably tell, it's much more nuanced than typically we would see with other drug clinical criteria. So with that, Alex, if you'll go ahead and kind of lead us through that conversation, and I can reference a couple of things if we need to in between now and then.
Yeah, definitely. And I don't know, Brandon, if you wanted to go to any other slide or the top drug slide or the top trending slide as a visual or illustration of like the drugs we're talking about here.
Yeah.
But
let's, I apologize. I was going to say, let's move to slide 8, please. Or
Yes.
Yeah, there we go. Yeah. And
yeah,
so,
that's great.
Yeah.
Yeah. Brandon mentioned a little bit about your overall trend and spend, and we see that on this slide here. So we have our data around our trends, specialty and non-specialty. Just a little tidbit about that. Utilization for specialty did go up. As Brandon said, there's only one new utilizer, but utilization, how we define it, is day supply. So there's more day supply this period over the last. And just one example of that is that drug quorum at the top. It's under anti-diabetics, but it's really not a diabetes drug. It's for a severe pituitary disorder and a lack of a certain hormone. That drug is about $500,000 in spend, and about $250,000 of that is new this period. But the member was on the plan in the prior period, right? So, in other words, they're on it for the whole year, all prescriptions throughout the year. So that's just an example of utilization and day supply going up. A lot of these categories are a lot of specialty spend. And as Brandon talked about, specialty is important, but, we can be sure specialty is being managed with your specialty guideline management. These are usually for very severe conditions. So with that, just as a bit of a backdrop, we wanted to spend a few minutes talking about non-specialty, primarily the drug Ozempic and drugs like it. I don't know if you've all kind of heard about these drugs or heard about them in the media and the popularity that these drugs are gaining. But the drug Ozempic and drugs within that category were originally developed for diabetes. They work great for diabetes. They help with glucose control. They even protect the heart, preventing heart attacks. They work so well, though, that they also work for weight loss. And they work so well that manufacturers recognize this weight loss benefit, and they rebranded them for weight loss specifically. So the drug Ozempic, that active ingredient, was rebranded into a drug called Wegovy, same active ingredient, but marketed for weight loss. So, that being said, with the advent of these drugs and the popularity and how well they work for weight loss, we're seeing a lot of utilization for these drugs. And for a plan like yours, we're seeing a lot of off-label utilization. And what I mean by that is we see folks that are using the diabetes drugs for weight loss because, again, they work so well. They're getting however they can get their hands on these drugs, folks are using them. And your plan, doesn't cover prescription weight loss medications. But with that off-label utilization, we're seeing these diabetes drugs being used, in instances where we think they're probably being used for weight loss. So what the Smart Edit does is it looks at the history of your claims and digs back in. It looks at certain criteria, diagnosis, and claims history for 2 years. And the folks that we identify as using this drug for diabetes, they pass that edit. But for people who we think may be using it off-label for weight loss, we would put a prior authorization. And that's what the Smart Edit does. It identifies people who may be using it off-label, and it requires, more stringent workup and a prior authorization. And we bring this up because, we looked at your spend, and I'm looking at about 78 members we identify that are potentially using this drug off-label for weight loss. So there is there's an opportunity there to better manage this category, because right now, the county that your intention is to exclude prescription weight loss drugs, and by these folks are getting around that by kind of filling this off-label and utilizing this off-label. So I'll stop there. I don't know if there's any questions or comments around that, or if I can be a little bit more clear. It can be a convoluted discussion that may need some further discussion.
I have a question. So are the physicians actually writing the script for their patients for Ozempic that are that diabetic?
Yeah, that is the concern. And I was on the call with the medical director earlier today, and he had no qualms. He did not mince words that he believes that there's some prescribers out there that don't practice the way that they should, and they will often either do cash payment visits or what have you. But however it's happening, there is a subset of folks that are getting the diabetes drugs, Ozempic, but that's not the only one. There's other drugs that we're targeting here with this Smart Edit that would be getting the product without having diabetes, because the way that the drug works is benefiting these folks to lose weight, but they're not diabetics, of course.
So would your medical director from Aetna send a letter that you've identified the physicians that are giving out those scripts and slap their hand? Tell them to stop doing it? They're not diabetic, they don't get the drug. I mean, it's pretty simple.
Yeah. I think that might skirt HIPAA a little bit too close for art, because we would have to know, we would see the drug information, we would then use that to reach out to a prescriber where that interaction shouldn't have been public knowledge. We assume that patient confidentiality rules there, and that, as Alex had mentioned, the prescriber would say like, well, he's pre-diabetic, so we're going to go ahead and head this off and prescribe Ozempic. I mean, that conversation would be pretty easy to have, but
Yeah.
Specifically targeting members because of the drug utilization, to curtail that, I think would be a little bit too close for,
Well, I wouldn't identify
Yeah.
as name.
but we would have to in order to reach out to that prescriber.
Well, let's say it's
We-
Dr. Austin, Dr. Austin, and he goes in, and you can have a very simple conversation with him and say,
Yeah.
we've identified some of our members, your patients that are diabetic. Could you kind of speak with the nurse or, go back and he'll go back and he knows who it is. He knows which ones he did, if he's doing it. I'm not saying he's doing it.
Well, and I think, kind of to Alex's point is the smart edit does that automatically so that we don't have to avoid HIPAA. We don't have to run into HIPAA violations. The smart edit will say, if you don't have a prior history, then we'll reach out to the doctor and say, where's the criteria that we're using to prescribe an anti-diabetic medication to someone who has no history of anti-diabetic medication pills.
But you're doing that now, and 78 members still get the.
Well, there's no criteria in place now for anti-diabetics. So the smart edit would add a criteria, we call it smart because it's not everybody. So if you've got a history of any anti-diabetic medication in the last 2 years, automatically pass through because we can see a history of anti-diabetic medication, insulin products, whatever the case may be. If you don't have anything and all of a sudden you come up with a prescription for Ozempic, that will trigger a further clinical oversight that we will have to go through, virtually a PA process.
Okay.
To say, hey, I'm newly diabetic, and we can figure that out pretty quick with the prescriber. And then at that point, again, we're not hindering access to the diabetics that need this. We're hindering access to the non-diabetics that want to use it strictly for weight loss.
Hey, let me jump in, Brandon, if I can. I'm not an expert on this area of the business, but, I do periodically sit on a monthly audit call where we do audit pharmacies, we audit doctors when, there's unscrupulous or potentially illegal behavior. But that being said, it's not necessarily that we're able, I think the doctor is speaking just from anecdotal experience, but, I think these instances where this is being used off-label, my opinion of it, it's not necessarily something that would be illegal. It would just maybe be not clinically recommended. But remember, doctors prescribe off-label very often. But this class is a little bit unique in the sense that they're new. There's a separate drug category for these drugs. And, it's my clinical recommendation that, really we shouldn't be using off-label. We should be using, for the labeled indication. And the other point that Brandon made is once a smart edit is in place, we require a diagnosis with documentation, meaning chart notes or other documentation from the prescriber. So that gets the prescriber involved with making this decision or providing us the documentation that this person is a diabetic. Or, if in the case that they can't, then, we would exclude the drug.
So, and just very quickly, this is much more nuanced than we would typically see because of the other side of this, where we see vastly improved clinical outcomes for those that lose weight at whichever channel they've taken. So there's a much more philosophical conversation that kind of needs to be had around weight loss and drugs, because we know that we can improve clinical outcomes across the board with weight loss. However, is that something we want to finance with the pharmacy benefit or not? Very mixed approaches across the board through our employers on how they do want to cover it or not cover it. Something that we can absolutely have as a separate conversation specific to this. And I know you had a question, and I want to make sure because I think we're right at time. So
I just wanted to clarify, so that smart edit is not a tool that's currently part of our plan, but that is something that we could add to it, right?
Correct. We can add it at any time. There's no impact to rebates. It would just put in that extra criteria for this drug, for not only Ozempic, but a few others as well that we've seen for use as a weight loss drug for non-diabetics. It just curtails that utilization to ensure that the diabetics are using the anti-diabetic medication. And then again, we can continue the conversation around weight loss and how we want to cover that going forward, given that this is an extremely new category, and it's in and of itself, but again, philosophically, the increase in spend on the pharmacy side using to improve outcomes on the medical side and what we've seen previously. So again, much more involved conversation that we can absolutely have at a later date, but.
Well, and another thing is that the diabetics aren't actually getting the Ozempic because they run out. They can't make it fast enough.
Exactly.
And so members are calling every day, calling all up Walgreens, you have it, and running to the pharmacy.
Yeah.
Like, what?
So we're hoping that this catches on not only with our employers, but with other carriers and helps, again, curtail utilization outside of diabetics because, you know, in the hierarchy of people that need an anti-diabetic medication, the diabetics are probably at the top and those that need to lose weight are at the bottom.
So what we'll do is we'll gather more information as to what it's going to entail. Once we gather that information, we'll bring it back to the board for discussion and obtain the board's direction on it.
If we can have the number of members that are actually diabetic and audited Ozempic.
Alex, do you have that as on the utilization that you ran? Do you have the number of those that are diabetic that we see would pass the criteria?
Yeah, so I have, and I actually misspoke because I've ran a lot of these. So your plan in particular, there's 49 folks on these drugs that, you know, would not pass, that would potentially be using off-label. Regarding the folks, the total, I would go into, but I mean, just Ozempic alone, there are 53 utilizers, but we're looking at other drugs as well. So 49 people that are identified potentially impacted by this smart edit. And then the other people, maybe I can put it into the chat because I would need to look at these individual drugs, but Ozempic alone is 53 folks. So I would say between like 75 and 100 people total would be using the drug.
And half of them are using it off label. So with the edit, you open up, you know, again, you're hoping that this catches on and that you open up that drug to the diabetics and again, steer the weight loss utilizers to another avenue.
Yeah, it'll be interesting to see next year, same time, to see what the number is.
Yeah, and we've
How much
seen
it's going to grow.
It's already grown tremendously. Even in our book of business, I mentioned it's number 2 right now. So,
okay. Thank you.
I want to be cognizant of time. Are there any other questions I can answer on the pharmacy benefit before we pass it over to medical?
On page 17, where you say putting the brakes on specialty spend, if you can talk a little bit about that. Just, I promise not to ask too many questions.
No, this is, let's see.
Wait, did you want me to answer that question, Brandon? Could you repeat it?
Yeah, if you're there.
What was the question?
Yes, absolutely. She just, you know, when we say putting the brakes on specialty spend and what that means, not necessarily curtailing utilization, but making sure that we're utilizing the tools that we see here that are built into our administration to the best of their effects.
Yeah, so there's so many facets of our specialty management, but I'll mention one facet is our specialty guideline management, which is our utilization management for specialty drugs specifically. That is our clinical criteria to make sure the right person is on the right drug. We always are looking to update, improve, and stay up to date with clinical guidelines. One example of that is within the autoimmune drug category. I'm mentioning this category because this is usually the highest specialty spend category. Usually about 40 to 50% of a plan's specialty spend is on autoimmune drugs. And we recognize that as, as a critical therapeutic category. And within the last year and a half, we have updated the clinical criteria in that category to make it tighter, to tighten up the brakes, if you will, and require certain documentation and just new clinical criteria around that category. So that's one example of how we're like always looking to update, always looking to improve upon our management. And that's kind of partly what we're talking about on this slide, amongst our other, capabilities.
And so within that category specifically, autoimmune year to date has accounted for $43,000 in net savings of the total $132,000 in savings through our PruneRx program. So as Alex mentioned, it is the lion's share of what we see in part of utilization, cost, and also thankfully savings through that program as well.
I just know that there's a lot of members, and the people with autoimmune diseases are really sick. And I'd hate to see that, since we're trying to worry about cost here, that we're penalizing the employee because we're too worried about money.
Well, so I mean, the good thing now is that the employee, assuming they meet that criteria, and with the autoimmune, if they're very sick, it's pretty easy to show he's got an autoimmune disease. And so Humira will treat that. So with PruneRx in place, they don't have to pay for it.
Yes.
And with that, we've even netted more savings than we've spent given the same criteria. So it's not putting the brakes on spend regardless. It's saying that we don't want, as Alex mentioned earlier, Corlin at $50,000 a year and spend. We don't want that to walk out of your bank account without us saying, yes, we looked at this. We made sure that whoever's taking it, whoever prescribed it, where they're getting it, what channel, was all in line with what we would expect. We don't want these members to not have these drugs. It's kind of a mirror of the medical benefit where, like, if everyone's perfectly healthy, no one's going to the hospital, right? Mm-hmm. But on the pharmacy side is if we had no pharmacy spend, that means your diabetics aren't taking their insulin. It means your antihypertensives aren't taking their heart medications. It means your autoimmune patients aren't taking their Humira. We don't want that. We just want to make sure that the money that you spent, which is not insignificant, especially within specialty, is done so at the most efficient manner possible. But that, again,
and one example of that is like step therapy or quantity limits. That's a break to kind of reevaluate therapy, start with a lower cost drug before you go to the more expensive drugs.
It's not as restrictive as you would, and the prescribers have helped us develop a lot of this criteria as well. But again, it's in line with what we're seeing, that we're not restricting access. We want to make sure that it's being done so in the most efficient manner, because at the end of the day, our cash with which we use to provide these benefits is still a finite resource. So we want to make sure that everyone gets exactly what they need. And in order to do that, we've, with the help of our prescribers, developed clinical criteria, especially within specialty.
Thank you.
Yep, absolutely. Any other questions? No? Thank you very much for your time.
Thank you.
Thank you. Thanks so much.
Next, we'll be going over clinical, right?
Yes,
Yep.
the financial and medical.
But I'm sorry, no action on item number 7? It's still part of, this is all of it, I'm sorry, I'm getting ahead of me. After this one will be the medical portion, and then.
Okay. My name is Lindsay Smith. I am the Senior Analytic Consultant for the County of El Paso with the Aetna side. It's nice to see everyone today. We're going to go ahead and go right into the medical report highlights. So slide 3, please. So from the medical perspective, it looks wonderful. Your trend from 2021 to 2022 is negative 25.4. Quite a bit of this negative trend is caused by your high cost claimants. You had a significant decrease in the impact from those. You had a negative 20.8% contribution to medical trend from those individuals, with a 30% decrease in the total volume of high cost claimants, and a 54.5% decrease in catastrophic high-cost claimants. Catastrophic high-cost claimants are anyone that's 300,000 and above. So those very sick individuals. Your average pay for high-cost claimants did also decrease by about 20%. One area that you did have some medical trends from last year was your ER. We'll go into that a little bit later. You have seen that increase in ER utilization. Okay, I'm actually going to skip ahead. I know we're a little bit short on time, and I want to give Pam some ample time to go through some of the clinical pieces. If we go to slide 8. So this is looking at your trend for utilization and cost by your medical cost categories. So your cost categories include inpatient facilities, outpatient facilities, ER, physicians, and so forth. What we're seeing for the County of El Paso is that you've had that 25.4% decrease in your PMPM. For your visits per 1,000, you have had a decrease of 0.5%. And for your cost per visit, we have seen a decrease of 25.1%. Where you're really seeing any sort of increase was in that ER. Everything else has a negative contribution to trend. So you're definitely moving in the right direction compared to 2021. Where we're seeing that increase in your visits per 1,000, the only one that's significant is your ER. You are starting to see an improvement in primary care physicians, which is great. We want to see that. We want to see people going to their primary home. You've also seen some increases in lab and home health. One thing to point out, if you look at your cost per visit for medical RX, it does show at 15.7%. That is artificially inflated due to vaccinations. In 2021, you had that influx of COVID vaccines, and you did not have those in 2022. With using those, the spend for those, it did make it look like your costs went up. However, if you exclude those immunizations, you actually have a negative 0.5% for your overall average cost for your medical RX. Okay, I'm actually going to, again, skip ahead to slide 10. This is looking at your COVID-19 impact. So for this, we did look at your trend overall from 2020 through 2022, as well as looking at each individual year. Really, the story here is that you are continuing to see your costs go down for COVID. We did have the national emergency that was ended last week, so you are going to continue to see that decrease. But what you're really seeing is that the shift in your spend. Whereas in previous years you had more spend in your inpatient and your ER, you're seeing this shift to more of that outpatient spend and that testing. So that's a good thing as well. And with having those home testing, it is making it easier for individuals to take advantage and have those readily available. Any questions so far? Okay, perfect. Next, I'm going to go into ER. So if you will skip to slide 13. So since this was your cost driver, we did want to spend a few minutes here. Your total ER visits for the year were 929, which were 4% higher than last year. It accounted for 14.4% of your total paid for the group, and was 0.3% of your total contribution to trends. We are seeing a slight change in your PCP to ER ratio. That's indicating how often does your member go to a PCP versus an ER. And it did go down slightly to 9.7. We'd like to see that at 11. So this could be an area to remind members that there are other options. I know it's been extremely challenging to get into PCPs, but there are minute clinics, and I know that you have the County of El Paso has the clinics as well that the members can utilize.
So I have a question.
Yes.
For the ER, you consider urgent care centers ERs?
No.
Okay, so it's at a lower rate than
Correct.
the ER. Okay,
Yes.
so then there would be communication to the members to go ahead and use, because sometimes in the weekend you don't have a doctor, or it takes 45 days to 60 days to get in.
Mm-hmm.
So that would not be considered. UUCs are not considered.
Correct.
and you have portion clinics, extra facilities.
Mhm. Yes, this is strictly looking at both your hospital ERs and your freestanding ERs.
Okay, so then for the ER, you've got UMC at 290 versus the rest are a little bit lower.
So this,
What are we doing about educating our members? Probably not to go to UMC ER or any ERs, but, and then my next question with that is, out of Tenet and UMC, who has the highest rates? Is it UMC or is it Tenet? Because when you go back, I don't want to call the word steerage, but you're going to inform your employees that, yeah, it is less expensive to go here. And here are the numbers. You can do that without telling them the rates. Rosita, I'm sorry. I don't want to see the rates. Yeah, so it would lower the cost.
Mhm.
And they'd be like, well, we didn't know, and it's gonna cost them more, so overall, don't go to ER, and if you are gonna go to ER consistently, go to this one, which is less expensive. So which one, are you comfortable sharing in terms of the least expensive?
So I could look at the average cost based on the plan. I don't have that readily available.
That's all right.
But I could definitely
You
be
can,
So I was just gonna mention, it's, we're kind of in the middle because UMC is a county hospital. So it's like a sister facility. And of course, we do have the UMC network plans where they get a better rate. The employee gets a better rate by
Okay,
utilizing
so they're the lower
UMC.
rate, okay. Because I did have a conversation with the commissioners, and my ask was, what is our focus? Is it cost? Or is it to send all the patients to UMC? Or is it that get the best rate? And the response was, no, it's not to steer members or employees to UMC. Like, okay, because it sounds different here when we're in the meetings.
Well,
but-
a couple of years ago, the previous court wanted us to push employees, to steer employees to utilize the UMC clinics, the UMC hospital,
And it makes sense,
because
but
it
then-
was being, they were having a low utilization. So we had a different direction.
Mhm.
And again, because it is a sister company, the funding is all county, if that makes sense.
Yeah, Yeah.
The funding going to UMC, so we have a shared interest, so to speak. But that's why the rates are different between the county and these networks that we have in place with UMC. But we also have rates with Tenet, so that's why it depends on where the employee seeks services. Is it more with Tenet, is it more with UMC, or is it both?
I have a question, or an interpretation of that. My understanding is, it was in the past, tended more, when I came in, more to tend toward the tenant. And as time progressed, the option was given to support more. So it was, as you said, a sister company, entity, so that versus private versus another county entity, it's more from a different vantage in that it being options available, not necessarily this private company or this county company, but rather what do the people, what options do they have available to them? And it opened it up. Hence the Mexican utilities are available, et cetera, not necessarily the bottom dollar or direction, but rather how do we support the employee? It's benefits to the employee at a reasonable price, not necessarily the cheapest, but reasonable. And hence we have multiple options for them.
Right.
So that's why I was wondering. That's how I understood it versus the county commissioners, whatever time period, going this way or that way. From my observation, it went entirely different route. Was let's take care of the employee. what can we offer them instead of one path only? Here's multiple paths. You choose, here's your information.
Right.
That's my
Yes,
interpretation.
and that's why we've made those networks available.
Right.
So the employee has those options, and of course, the rates where it's gonna also benefit the health plan. And so because the board has taken the direction of providing those options to employees, that has also affected the claims and the claims cost really based on these different networks that you all have approved to put in place.
So the best bet at this point is to further educate the employee for not only their choices, what's available, their choices, but effects.
Correct. And so every quarter we have our Aetna representative provide trainings. Actually, tomorrow she's having a training which is regarding the Aetna programs. So we're providing all these educations to employees. We do outreach to specifically who is on a certain plan, and we say, this training is for you. They're going to talk about your plan, how it affects you and how it works. So we're, little by little getting employees educated on how their plan works, what other plan options are there, which one fits best their needs, their health needs.
And based on that interpretation, this page 13 on the tenant and UMC, doesn't matter which plan, data just is not to highlight one over the other, but rather, here's how it's happening. And that's why I'm saying, rather than investigating something that's been decided, that we're actually judging what are the results of our recommendations.
Mm-hmm.
And at that point, if the commissioners want data, there it is. Can it be improved? That's a different question.
Well, and that said, there are some people that are, and I brought this up last time, that are unhappy with the plans. Specifically, the tenant and UMC. And there's a commissioner on board that says, I picked tenant because I love tenant. That's where I go. That's where my family goes. Oh, but guess what? If I choose tenant, then I'm penalized because I can't go to UMC because I have a headache it's right across the street to the clinic. She can't go to the clinic. And I'm like, why didn't you go to the clinic? And she said, no. So then, my husband said, well, yeah, this and that. So there are people that it's perceived that we're not helping the employees as we should. We're basically saying, this is what you have, take it or leave it. If you choose tenant, you're going to have to stay with tenant. And you can't use these ones over here. So you're kind of like, well, but the clinic's here. I want to go to the night clinic or the clinic's by my house. So if we could kind of work on that next year, because number one, it's confusing. Number two, then they're upset. And you don't want upset employees or commissioners because you've just kind of basically, you're the wrong one at this. And she's still saying that. She says, I don't know what they did this year, but it was a lot of confusion, and the perception was it's not about the employee. It's about steering all of the members to UMC.
That's not the direction.
Yeah, I hope. Okay. Yeah, but let's put it out there. But yeah, I hope, or the courts hope that it's not, because I don't want anybody to say that we approve these plans, and that's why they're stuck. They're stuck because you gave them information and they didn't understand it.
We're evaluating, please know that staff is evaluating based on these numbers, the cost based on the networks. What is it costing the plan? And so we bring that information to you to make a decision on, do we want to make changes to what we're currently offering? That's absolutely.
Or open it, really open it, have them do whatever they want. If they want to go to it and
they do. They have the option of, based on where they seek their health services.
Well, they have the option of going to tenant or UMC. But
no, there is a traditional plan.
Oh,
yes.
Yeah, that's true.
Can I just make a comment?
Yes.
So I think when the decision was made to implement the UMC and the tenant ACO, you understand that those two facility or those two provider groups are part of the core and part of the high deductible. So we ran a geo access to say how many people are currently utilizing Tenet, how many people are currently utilizing UMC. And so if they were already predominantly using those provider groups, the county thought, well, let's put in an option. Since they're currently using those providers, if they select those plans, there's a reduced premium for them. So that was the intent and the overall goal. And on top of that, in addition to just having that ACO, Tenet ACO tier and the UMC tier, the county's offering an out-of-network tier alongside that. Many customers in El Paso that have moved toward the ACO have zero out-of-network. I mean, you guys, the county has taken baby steps toward the whole concept of the ACO and of that model. And every other customer, the predominant customers in this market in El Paso, some of your school districts have become more aggressive, and they're saying, we're gonna create 4 plan designs that are strictly ACO and 0 out of network. So I'm just giving you a feel for what's going on in the market and really what the overall objective was initially when these were put into place.
I'm new.
Yeah, and then also I think Lindsay, these numbers down here at the bottom that show the visits per thousand. Now ER is one of those benefits that you're not restricted. If you're in the Tenet ACO or you're in the UMC network, and you've got to go to the emergency room, any emergency room is going to be in network or considered at the par level. So, and then you have to look at the population size. The vast majority of your population are in the core and high deductible. Correct. You have very little numbers in the other 2 plans. Correct. And so the goal for the county should be going, with forward thinking, is how can we maximize those savings opportunities under Tenet and UMC for those folks, that are already utilizing it. And honestly, those are probably the top 2 facilities in this market. UMC does an amazing job. They have, what's the trauma level? Yeah, level 1. And the Children's Hospital, and then Tenet, my gosh, for years it was like the provider of choice. So how can you consider that a bad option when that's really almost one of the premier provider groups in the market?
Okay, well, I'm just hoping that we have that discussion within the next couple of months so that it'll be clear that this is our focus. And
the focus is to make sure that the risk fund is healthy. So as long as we can reduce the claims cost, as of course not adding the entire cost to the employees, for it to be competitive and still affordable for the employee.
And satisfy the employees.
Either pocket.
Okay, thank you.
So one thing to note with ER, looking at the specific days of the week, 31% of your ER visits are occurring on a weekend, a Saturday or Sunday. So you do have limited options when you do hit the weekend. And then actually, if you look at the next page, so you can see that your ER visits per 1,000 for ER was 224. If you look at your ER or your urgent care visits per 1,000, it's double. So you are seeing members that are utilizing these minute clinics and these urgent care clinics. So it's really good to see these increasing. It's a lot of it is still just continued education. I think when you're in an urgent or emergent crisis, most likely you're going to try to go wherever you can find care. We do want to make sure that individuals do know what options are available to them.
And can I add something there on page 13, going back for 1 second, and just clinically speaking, one thing to really think about is it truly an emergency, or is it preventable to where it can go to an urgent care or a minute clinic? So you can see here that 35% of those ER visits actually were preventable and could have gone to a PCP instead. Mm-hmm. So when we talk about doing what's right for the employee and such, that education, that saves them a ton of money by not going to an emergency room versus a minute clinic or an urgent care.
Well, I'm glad you said that. So when you go to the ER, would they triage those patients and say, you know what, this can wait. This can wait till the doctor's there on Monday.
No, you're in the,
No,
Most of the
it's
time,
not part of the protocol.
They won't triage them?
well, they
Okay.
triage them, but
Well, what if
if
they're not, you know, they're
you're,
not very sick?
you're still being seen by a physician in the emergency room, and so you're gonna be charged
Billed.
the emergency room versus going to, so for somebody that has had a sprained wrist for 4 weeks, they should not be going to an emergency room. My daughter works in San Antonio in the emergency room, and you see it all the time. People will come in and that's not an emergency, you know? And I hate to even say that, but emergencies should be emergencies. And if it truly is an emergency, no matter, as Mike was saying, no matter where they go, it's going to be covered as in-network because of it being an emergent. So that education on making sure they understand the difference between an emergency and not, if it's something that's been going on for a while, that is not an emergency, you know, so.
Can I make a comment about the, on this slide, you see the box where it says members with equal or greater than 4 ER visits, and it says 25. So there are 25 people that have 4 or greater emergency room visits. What we tend to do on our side is when we see that number, and in all honesty, in comparison, that number is lower than many of our customers. But we look at that, we pull those 25 and we say, what's their primary diagnosis? If they're cancer, if they've got, you know, a significant chronic condition, the chances are that they're having episodes in the evening on weekends where their provider's saying, go to the ER. I can't see you, go to the ER. So in those situations or circumstances, we kind of watch them. The ones that are going for, you know, cold or unnecessary, non-emergent, we kind of forward those on to our clinical team so that there's an opportunity to outreach to say, you know, we noticed you're going to the ER, is there a barrier? There are alternative, you know, sites of care that are more efficient to address your needs. So it's an educational perspective.
Because you have some people, that use the ER as a PCP.
Yes.
But I will, you know, you mentioned earlier about do they triage in the ER to go that, no, you're not ER appropriate. If you go to an urgent care or a minute clinic and you need to ER to be in the ER, they will send you to the ER. So it's exactly the opposite.
But then they know that they really need to be there.
Absolutely.
Because you've got the sniffles.
Right.
Well, and also too, COVID. When COVID was here, everybody went to the ER. So it's kind of changing a little bit of that mindset of getting them back into the saddle of understanding that they need to reestablish those PCP specialist, you know, relationships and kind of get out of the habit of going to the emergency room for just, you know, everything.
And to Berenice's point, you do have Chloe, the Edna on-site, who actually supports your membership, and all those trainings that she's conducting are key in ensuring that these numbers do go down, right? You don't want to steer them away from ER. You just want to provide the education of knowing when to go to the ER and when to step away.
And we want to steer them away from the freestanding, but that's, you know, we really can't do that either, other than just, you know, educate that try to go in network, try your best to go in network.
Is there a way to incentivize the members for not going to the ER?
To what? Incentivize?
The members.
Well,
for not going
there was
to the
one
ER?
point in time, I think, and we talked about this, Denise, correct me if I'm mistaken, but we discussed establishing a differential between a hospital-based emergency room and a freestanding. So let's just say your copay's $250 if you go to Tenet or UMC or HCA, but if you go to Sun City, it's $500. You know, we can do that, but your copay, I think, was already pretty high across the board, right?
No, we already did.
Oh, you do that. You're doing that now.
Yeah.
Okay.
Okay.
So there is a little bit of a differential that they implemented. So that's one strategy.
Yeah, that's a
The other strategy, though, is that some of these freestanding, when they first started coming in the market, they were balance billing a lot. Now they're not really doing that. They're just accepting whatever the insurance companies are paying and you know, waiving the rest or wiping it off their books.
Well, and if the employee has Aetna or any plan and their children are under Medicaid, that's it. They all take them to the hospital. They don't go to the doctor. They just take them straight there. I mean, how dare you, you can't bill a Medicaid recipient. But there they go. Okay, thank you.
Now I'm going to turn it over to Pam.
Thank you. Okay, I think I've met most everyone. I'm Pam Cody. I am a registered nurse, clinical program consultant with Aetna, and for County of El Paso. So I will go very quickly through the clinical. I'm just going to highlight a few things on here. So looking at slide 16, let's take a look at our diagnostic categories. So digestive GI, that was your number one top diagnostic category. It was 10.4% of your total spend, followed very closely by MSK. And then your digestive was really driving the non-high cost spend by about 1.3 million, and that had to do with ER visits. That was primarily ER that you were seeing. And that's why that it is so high like that. Your high cost claimant spend was driven by newborns. Your number 2 high cost claimant was a newborn baby. And so that, that's not unusual to see. Cancer, it's had a significant increase from prior. It is now utilizing, 9% of your total spend by diagnostic category. And that's up 4.9 points with a 2.7 contribution to trend. And then looking at non-specific, that's in your top 5. We want to see non-specific up as close to the top as possible. That includes your preventative care, and that's a good thing. So wellness, preventative care, all that falls into non-specific. Okay, moving on. Slide 17, all I will touch on here, and Lindsay really kind of touched base on this. You had a decrease. You only had 19 high-cost claimants versus 27, so a 30% decrease. Your employees are driving that, and again, it looks like your your oncology was driving that. You had 5 high-cost claimants there. On slide 18, I actually did, you all can read this. I know you have the printout of this. This actually goes into your top 5 high-cost claimants. I will say that your number 4 did have a COVID diagnosis that was sent over on your monthly COVID report. So you all have already been made aware of that one. But the others, the one thing I did want to point out here is 3 of these 5 actually were engaged with one of the ethnic care managers. So that's great in being able to have that support. Briefly on the next slide, population health. Everything looks great as far as your screenings and your preventive visits. They are all well above book of business. On your risk on the right-hand side, your inpatient severity risk, your retrospective risk for both your member and employee, everyone decreased. Your inpatient severity risk index is a little higher than book of business, showing basically the acuity of those going inpatient, while your retrospective risk score for your member is right at book of business, and your employee is just slightly above book of business. And what your retrospective risk score is actually like how sick your population is. That's what that's.
So I have a question.
Sure.
Case management says member remained unable to reach Aetna care manager.
Yep.
That happened with 2 patients.
It did. It happens with a lot of patients. They don't answer.
Mm-hmm.
And I am going to look at your case management because your engagement numbers are incredible with case management. There is either they start out by sending a introductory letter whenever the algorithm triggers them. They get an introductory letter. They make at least a minimum of 2 phone calls, depending on what the trigger is for. Then they send an unable to reach letter. All of those, they'll try multiple times to reach the member. If they can't reach the member and they're inpatient, they'll assist with discharge planning. They'll assist with utilization review and things like that. So it does happen. Unable to reach definitely does happen quite some time. That's why it's so important when we have open enrollment Also to make sure you have correct phone numbers, correct emails, correct, I mean, it changes, it changes very often. So I will go a little more into case management here in a few minutes. So on the next slide, the key impactable conditions, the only thing I really wanted to point out here is both employees and spouses, hypertension and hyperlipidemia are your highest prevalence for both of those. So as Brandon was mentioning earlier about Hello Heart, we don't have the data, but it was implemented in May 1st, in May. And so I'm excited to see next year what that shows. And so hopefully we'll be able to see some impact by then on that. So, and then on your dependents, asthma is what's driving their prevalence on asthma, which is not uncommon. Maternity, your next slide, the big thing I want to point out here is your C-section rate has gone down tremendously and is now below the national statistical average. So that is wonderful at 28.1%. And also your mothers that are enrolling in the maternity program, 53.1%. That's 18.1 points difference. That is incredible. So whatever you guys are doing on your incentive, keep doing it. Like it's working, it's beautiful. I don't think I've ever seen that high. That's beautiful.
As you can see, the expected with the program is just under 10%.
Yes, so. And you have 53. So that's amazing, amazing. MSK, I wanted just to speak briefly since that was your number 2 on the next slide. So musculoskeletal, just briefly on that one, you do see a decrease on your per month per member cost as well as the average paid per claimant. However, you see your high cost claimant percentage up just slightly, and that's, you did have 4 high cost claimants that were related to musculoskeletal. 2 of them were spine surgeries, 2 of them were emergent fractures, those sorts of things that needed to be seen in the hospital. I am going to skip over to 24 unless anyone has questions. All right, looking at cancer, it's 13% as a percentage of your total medical paid. You see your top cancer sites, other cancers, so anything that does not fall into a specific category basically gets dumped into that other category, followed by breast cancer, skin cancer. And then this last one, the head and neck, is all the same numbers there, all the same, the dollar amount, that's because that's the same number, head and neck cancer, and they have lung cancer. And so that is that number there. Your by percentage of your, the types of cancer, so the percentage of your membership, other is 38.3%, breast cancer is almost 26%, prostate is about 11, skin is right at 8 or 9, and then leukemia and myeloma, so your blood cancers are about 7%. Medical RX does count for about almost 56% of your total top medical cost paid, and chemotherapy is about almost 16% of paid by the diagnostic group. Moving on to 26, let's look at behavioral health. This is a good hot topic for everyone. So behavioral health, you did have a decrease in the total amount paid. Your prevalence is 14%, which is below the book of business. You can see that you've got telemedicine visits. People still are using telemedicine for behavioral health, which is very positive. Some people don't want to go and see someone in person for that. And you had an increase in the percentage of members that are accessing those services. So that's good to see. We definitely want to see people accessing BH services. The big difference on this one is your employees are now driving your mental health paid by relationship versus prior, that was your dependents that was driving it. And then on the next slide, you'll be able to kind of see what those conditions, those top conditions are. Anxiety and depression, we definitely see across my entire book of business, we see anxiety and depression. And you have to see that's worth over $6 million in total paid for claimants with that condition right there. When just looking at those two, you go from 7.9% for depression and drop down to 1.9% prevalence for attention deficit disorder. So that's a huge drop right there. Just to point out, Able To is one of the programs. It's a wonderful program where they can treat depression and anxiety. They get sessions, 2 sessions per week. It's for an 8-week program, and it's great. I have, as a case manager myself, I referred many people to Able To. You did have 592 members that were called, and then connected, you had 159. So I know that seems odd for it to be that much, but remember the demographics of the diagnosis you're looking at. So for us to have 8 people enroll, they actually enrolled, and 3 of them graduated from the program, we had an impact on those people. Whoever those 3 were, we definitely had it. I mean, you're taking out 2 sessions for 8 weeks, 2 times a week to sit and talk to a counselor. I don't know many of us that have time to do that. And so I think that that's incredible. So I wanted to make sure we pointed that out. So your case management on the next slide. This is pretty phenomenal. So if you're looking at your eligible member, so 4,600, we'll say 4,550, you had 363 that actually met the algorithm that were identified to have one-to-one nurse support. So whether it was an inpatient event, whether it was a certain diagnosis, whatever the algorithm was, of those, 146 participated, which is 40%. And that is awesome. Like, that's incredible. That's awesome. In addition to that, your group coaching, we sent out 423 invites for group coaching, and then digital activity, you had 839. Aetna Advice, we call that our little nudges. And so they had a total of 3,502 nudges. That's about 2 nudges per unique member. So it could be for preventative visits, so breast mammograms. It could be for colonoscopies. It could be for any of those types of things. And so those come out automatically and go to those members, those unique members. And you can see those top 5 outreach categories below. So like diagnostics, preventable services and screenings, those things, avoidable ER visits. That's another one that Aetna advised us to send out the information as well on that. And when we're talking about pharmacy, I do know that the care manager, they often, I don't want to say often, that's the wrong word, they sometimes do get polypharmacy, where they're looking at pharmacy to see that the medication, some of them, they need to just get pharmacy input from it. And how you were talking earlier about, some of the medications, them starting at the lowest one and then working their way up to the more, did we use the word expensive? I don't know what word we used. Clinically, you really do need to start out at the bottom, because if you started at the top, you have nowhere to go. And so you really need to start at a baseline and be able to, to triage to see what works best. And your provider, of course, making sure that they're in the loop on that as well.
Well, and that, usually it's when you go to the doctor, he's the one that puts you on top.
Yeah.
You don't, they rarely start on the bottom.
Right. Yeah.
It's like, no, just go ahead and give you the numeric.
Yeah. It does happen sometimes.
Yeah, so we can't go down.
Mm-hmm.
And so that's why, we get upset with this.
Yeah, that's why I love what they're doing with the program. I think that's really amazing. So if you look at the next slide, you can see on here, we were talking about the unable to reach members. If you look in the middle, you can see here, because I know that you had asked about the 2 that were the high cost claimants. So if you look there's your distribution. So of all of those that were outreach, and you had the 146 engaged, you had 161, so 44% more than anything, are unable to reach. So it is, and it may be that they just don't, they see Aetna on there and they don't want to answer their phone. It could be a lot of reasons. The one nice thing is once they get the one phone call, they have a direct line to their nurse that can guide them through everything. So I am a huge advocate for that, for the care management. And then you can see at the top left, that's your per employee per month savings, $56 for that care management for certification, utilization, and then claims. And then just some of those unable to reach reasons are on the bottom left-hand side as well. So voicemail, no answer, or invalid phone number. And then,
do you go back and ask the hospital for their
oh yes, absolutely.
Case management team.
Absolutely. So when we're doing discharge planning, I say we because I did that for so long with Aetna before I came over here. When they do that, they actually do work discharge planning with the utilization nurse within Aetna, as well as the discharge planner at the hospital to confirm address and phone number as well. They'll do anything. We can do anything possible to try and get information. We will not email them unless we have permission to email them. And they can opt into that, I believe, whenever they have an open enrollment, I believe they can opt in to email, right? They can opt into that. Mm-hmm. So yes, any avenue we can in order to find a phone number, we absolutely do. Lots of voicemails being left.
Sure.
Yes. All righty, and I think that sums it up. I've never done it that fast before.
Good job.
Okay. Any questions from the medical standpoint?
You can refer back to the executive summary.
Yeah, let's do it. Let's go back to page 3.
Yeah.
Okay. Can you hear me? Everybody hear me?
We can hear you.
Okay.
Can everybody hear him over there?
So we typically like to keep the recommendations or the ideas at the tail end of the presentation. I think we hit on a lot of these during this conversation. The first one, of course, is to reevaluate. I think you guys had very successful 2022 with that negative 20 plus trend. And I think when you look at it from a plan pay, it was like less than a reduction of over $5 million, like $5.3 million was the end result. So going forward, there's always that idea to like, let's look at this and see, do we want to make some refinements, some adjustments, and when it comes to the contribution strategy to drive some of those folks that are in the CDHP or the core plan over to the UMC or to the tenant. But of course, these are just decisions for the county to make based on your budget and your needs. But just wanted to throw that out there as something to consider. Then on education, of course, ER was a topic of discussion today, so we want to focus and continue to promote the most efficient sites of care. You guys had an amazing minute clinic utilization on top of urgent care. And what's surprising to me is we don't even have any minute clinics here in El Paso. So your population is traveling outside the service area and are tapping into those minute clinics, which is a good thing. And El Paso is slated on our project list as an area, for potential expansion or growth from a minute clinic or hub perspective. So
where's the closest minute clinic?
What the concept of the minute clinic?
No, what's the closest?
Would it be in New Mexico? Would they have them in New Mexico? In like Las Cruces, maybe?
How far do they have to drive?
No, I think they're just going outside of El Paso. I mean,
It could be when they're traveling, like if they're in
Come upon
California.
yeah, when they come upon it. Yeah. Have you ever seen a minute clinic?
No.
Oh, they're amazing.
Yeah. It's really cool. I mean, they're amazing. They're kind of like a walk-in clinic that treats acute care and prevention and even have chronic condition management.
So you're gonna have it by the end of this year? That was what I heard.
I'll see what I can do. I'll see.
We'll make a phone call.
Yeah. The next one is the county El Paso clinic reminders. I know that's very important to the county to kind of, educate your folks on those low-cost options available within the clinics. And so we want to continue with that. And teledoc. I think you had a reduction in your telemedicine, your teledoc utilization, but that's kind of expected with COVID kind of being in the background now. But of course, it's an option. We want to continue to make sure that they're aware that it still exists. We talked a little bit about digestive health being your number one diagnostic category. We have a program called OSHI. We will send some information, some collateral on that program to see if it might be something that the county wants to consider. And then the other two programs were the Aetna back and joint. You know, you guys had some spend around the musculoskeletal. This program is kind of focuses in on knee and hip replacements, making sure that, you know, protocol is being followed and the most efficient facilities are being tagged to, you know, provide those services. And then Transform Oncology. I can't say enough about this program because you guys had an increase in your spend in cancer and your increase in volume, your number of cancer members. This program kind of helps connect all the dots for a member. Oftentimes a member, when they get that diagnosis, it's like deer in the headlights. You leave an office and you don't really know where to go and how to make all those connections. This program provides like an advocate that helps steer them through the medical process, making sure that they're aware of all the bells and whistles that are available to them from a support and educational perspective. It also makes them aware of clinical studies that might be considered and community resources if they need, you know, support outside of what's available within the county or within Aetna. They're very, you know, in tune with what's going on in the community, and they make the member aware of those additional programs. So this is a program too that can be implemented without having a PEPM or an admin fee impact. This program is, I think it's like $79 per engaged member per month. So the county would only be charged or billed for those members that are enrolled in the program and that are actively engaged. So we'll provide additional collateral and to Denise, and then she can share that with you guys in the future to kind of consider whether this is something that you might want to think about.
And their site of care.
Yes.
Is another great thing. They have medications, specific medications, and if they are part of the Transform Oncology program, they automatically look at them to make sure they're at the correct location, not going inpatient versus outpatient, that they're actually at the correct, best way to explain it, right? Mm-hmm. Yeah, so it's phenomenal. It's phenomenal.
But who pays the $79? Is it the member or
The plan.
the county?
I like it. And just to note, Keytruda, which is one of those site of care drugs, is number 3 on your top 5 drugs. Yeah. And you have had a 239% increase in your visits per 1,000 to facilities for oncology drugs. So it's definitely an area that we are seeing higher spends in almost every client.
So we'll evaluate, we'll gather all the information, any potential questions that the board may have. So we have that data to present it on a future board meeting. Are there any other questions from the board on the report?
Great. So with that, thank you, Aetna, for your presentation. Do we have a motion to accept the Aetna pharmacy, medical, and clinical end-of-year report for 2022?
Motion.
Second.
Thank you. Trustee Asensio?
Aye.
Trustee Benhu?
Aye.
Trustee Hurtado?
Aye.
Vice Chair Salcido?
Aye.
Chair Quilty is absent. Motion carries. Regular agenda item number 8. Discuss and take appropriate action regarding the Risk Pool Board Annual Report for 2022.
Thank you. Today we have Joanna Falgoa and Ruby Munoz, who are joining us virtually. They'll be presenting the 2022 Risk Pool Board Annual Report. With that, Joanna, if you can hear me, I'll go ahead and hand it over to you.
Yes, thank you. Good afternoon, Mr. Vice Chairman and members of the board. Joanna Faldoa with the Human Resources Department. As Berenice Acosta mentioned, I will be reviewing the benefits portion of the 2022 Risk Pool Board Annual Report. Before I begin, I would like to point out that the pages of the benefits portion of this report have been rearranged from the backup that was sent to the board. I will begin with our risk pool board highlights and then give a quick overview of the benefit statistics. Before you are a list of significant actions that were approved by the board, in which I will be highlighting a few, such as the implementation of the board meeting every other month, versus monthly, which is how often the board would meet in the past. During the 2022 plan year, the board also approved covering the COVID-19 antiviral drug under the prescription benefit. In addition to this, the board approved 2 interlocal agreements with UMC in regards to employee flu vaccinations and biometric screenings. Next is the risk pool fund balance and UMC clinic report. Here you will see that at the beginning of 2022, our risk pool fund had a beginning balance of about $624,000, which we had not seen in some time. However, we were able to end the year with over $6 million and have been able to maintain since then. In the next chart, we can view the utilizations of the UMC clinic. As you can see on the chart, the numbers remain consistent for most of the year, with the highest utilization in the latter months, which may be due to the flu season. Next is the employee benefits the county currently offers. The county offers several ancillary benefits for its employees, in which the board oversees a few of them, these being the medical, dental, and Section 125 plan. The total number of employees that are eligible for these benefits for plan year 2022 was 2,785. Out of the 2,785 eligible, we had 2,595 employees enrolled for health insurance. We then have TPA admin and stop loss fees. Before you are Aetna's admin fees and stop loss premiums for plan year 2022. I will now go over the medical plan enrollment. On this page, we have the medical plan enrollments for plan year 2022. I would like to highlight that most of our enrollments are within the employee-only tier for all of our plans. From the 2,595 employees that are enrolled for health insurance, 2,500 employees acknowledge that they are tobacco-free. As you recall, employees receive a 2% premium discount if they are tobacco-free. This includes the employee acknowledging that they have been tobacco-free for the past 12 months and will be for the following 12 months as well. However, for plan year 2023, the eligibility for the discount has moved from the honor system to a test panel as part of the wellness screening. This was discussed with the board during the March past board meeting. It will be interesting to see how these numbers are affected since we'll be moving away from the honor system. Then we have the dental enrollment. On this chart, we can see our dental enrollments throughout the years. From the 2,785 eligible employees, more than half of them are enrolled for the dental plan. This may be due to the county paying the employee dental portion should they be enrolled in the medical plan. Next, we have the IRS Section 125 plan. In the medical enrollment section, we noted the county had 1,211 employees elected the consumer-driven health plan, which is our high deductible plan. On this chart, we can see that from those, 948 employees elected to enroll into the health savings account. I would like to note this enrollment has increased throughout the last 5 years. Moreover, we have listed the utilization and COVID-19 claims costs. Here we have a breakdown of the prescription, medical, and dental utilization. It shows the number of claims that were paid for the year and for how many members and what the paid amount was. You will notice that the pharmacy cost is much higher with a lower number of claims, meaning the cost of prescription drugs may have increased. Due to the pandemic, we had added a section to list the COVID-19 claims and costs to our report. Since then, the plan has paid a little over $5 million in COVID claims, of which we have been able to seek $1.6 million in reimbursement through ARPA. Within these claims, the plan paid about $500,000 in all COVID testing and a little under $140,000 paid on vaccine administration, leading to over 1,900 fully vaccinated members. Lastly, we have the Teledoc program. Teledoc, as you may recall, is the program that was approved by the board back in 2019. This service allows employees to access a licensed physician 24/7 via a phone call or video conference. The physician has the capability of prescribing medication depending on the symptoms discussed with the employee or dependent. For 2022, there were 373 Teledoc visits. Within this same page, we can also see the total net claim savings of over $176,000 for general medical claims to include a good percentage on member satisfaction. On this next page, we can see the average cost savings members had when utilizing Teledoc. This would conclude the benefits portion of the report. Do any members of the board have any questions? If not, I will now hand it over to my colleague, Ruby Munoz, who will present the wellness section of the report.
Great job.
Thank you.
Thank you, Joanna. Good afternoon, Vice Chairman and members of the board. Ruby Munoz, Wellness Specialist with Human Resources Department. El Paso County focuses on preventative and proactive approaches that address critical health issues on a yearly basis. Today, I will be presenting a summary of the 2022 Annual Wellness Report that also summarizes the wellness program and incentives we provide our employees year after year. Starting with our health risk assessment participation, the following shows the health risk assessment participation for the year 2022 and previous years to follow. We had a positive increase in most of the age groups shown and a total participation in the completion of the health risk assessment questionnaire provided by Aetna. Our overall participation was 997 employees who completed the assessment in year 2022. Next, we have our top 15 most prevalent modifiable risk factors. In total, we had 1,594 combined risk factors throughout our members. Our highest risk domain being weight. 455 of our participants fell within this risk factor. Next, we have our top 5 most prevalent health conditions. In 2022, the top conditions reported were hyperlipidemia, hypertension, obesity, nonspecific gastritis, and diabetes mellitus. The majority being hyperlipidemia, with 781 of our participants being at risk. Leading into our next section of top condition analysis for 2022. These conditions are based on our total population of benefit eligible employees, and the most prevalent condition was again hyperlipidemia with 781 in comparison to 764 in 2021. Our wellness program focuses on developing wellness strategies that specifically target identified diseases, especially those that are preventable like diabetes, obesity, and high blood pressure. With this being said, this leads us into our next table of conditions per employee. In 2022, we had 444 employees that were reported having 5 or more conditions. You'll notice that this number has almost doubled in comparison to 2021. We do foresee this number to increase as employees seek more medical care after the pandemic. 61% of employees can be impacted by prevention and education. Our wellness program allows for that measure to be met yearly. For example, the PLANT program that was recently approved by the board. This program will assist with targeting and assisting the employees in the top conditions we see yearly. Our overall risk levels are shown in this next graph. Each category, low, moderate, and high risk, are in close comparison to the previous years, showing moderate risk slowly decreasing. Our next section shows our performance measurements. This graph is based on presenteeism, and absenteeism. The table indicates the average percent of productivity lost amongst HRA participants while the participants were at work, and includes the percentage of productivity loss due to personal health problems and medical care. Please note that the units measured are a combination of days, weeks, and months per individual employee and their level of productivity. This next section highlights the amount of our eligible employees completed their annual wellness visit with their PCP. We had a total of 990 participants complete their annual wellness visit. Jumping into our next section of vaccinations that were offered to all county employees at no cost, the total of administered flu vaccines were 129 in 2022. We held 2 events. One was hosted by the city of El Paso, and the other was hosted by UMC. Our next section shows the number of trainings we held in 2022. We held a total of 19 classes with a total of 925 attendees in 2022. Some of those topics included mental health awareness in the workplace, nutrition awareness, targeting cholesterol, and much more. Next, we have our wellness screenings by Quest Diagnostics. In 2022, we had a total of 933 out of 2,785 eligible employees complete their wellness screening through Quest Diagnostics. The following graph illustrates female to male comparisons as well as year-over-year participation rates. Leading us into our wellness report card, this report card provides a review of the health risk factors for El Paso County employees. Top 3 risks identified for El Paso County employees include BMI, body mass index, blood pressure, and HDL cholesterol. Adam, if you could please take a few seconds on the next page to view the second page of the wellness report card. Next, we have our multiple risk factors. Employees with multiple risk factors cost employers more money in healthcare, absenteeism, and overall productivity. Multiple studies have shown that overall costs increase at a faster rate once the individual reaches and exceeds 3 risk factors. The next section is our metabolic syndrome report. The average age of participants with 3 or more risk factors is 45. The average age of participants with 2 or fewer risk factors is 42. Here you'll see a breakdown between genders with and without metabolic syndrome over the last few years. Adam, if you could please take a few seconds on each of the following 6 pages to view the remainder metabolic syndrome report. Our next section is our Healthy Lifestyle Reimbursement participation in 2022. The Healthy Lifestyle Reimbursement Program offers eligible employees an additional incentive to adopt and maintain an active lifestyle. Employees must attend and participate in activities at eligible fitness facilities at least 8 times per calendar month, for a total of 48 times during a consecutive 6-month period, or 96 times for a 12-month period. In 2022, We had a total of 42 applications submitted and approved. Next, we have our gym enrollments. Employees are given the opportunity to enroll in a contracted gym facility with a monthly payroll deduction. The contracted gyms in 2022 were EP Fitness and My Time Fitness. Last but not least, we have our end of the year raffle data. The end of the year raffle offers eligible employees an opportunity to win the main incentive prize of the year. The raffle consists of 4 $1,000 gift cards, 4 $750 gift cards, and 6 $500 gift cards. Employees who are enrolled in the county medical plan are entered into a raffle by completing one or more wellness-related items throughout the year. In 2022, we had a total of 4,943 entries into the end of the year raffle. And I am happy to report that we had 14 very excited winners. At this time, does the board have any questions? If no questions, staff is requesting approval of the 2022 annual report.
Thank you, Joanna and Ruby. Is there a motion to accept the risk pool board annual report for 2022?
Motion.
Second.
Thank you. Trustee Asensio?
Aye.
Trustee Van Hoot?
Aye.
Trustee Hurtado?
Aye.
Vice Chair Salcido?
Aye.
Chair Colte is absent. Motion carries.
Sorry, before we move on, did the board want to take a quick 5-minute break, or are we still good to continue?
Yeah. Good.
Thank you. Regular agenda item number 9. Discuss and take appropriate action on the restatement and potential changes to the health and dental summary plan descriptions to include A, revised effective date to reflect January 1st, 2023. B, added language throughout the document to reflect Aetna's administrative responsibilities. C, revised and or added language to clarify enrollment periods for Medicare coverage for retiree and or their dependents. D, added language to identify where members are able to locate provider network information. E, added language to clarify continuity of care. F, revised and or added language to clarify emergency and urgent care. G, added a definition for emergency services and removed the definition for emergency care. H, revised and or added language under medically necessary medical necessity section. I, added a voluntary and involuntary services section to reflect the No Surprises Act provision.
Thank you, Claudia. Good afternoon, Mr. Vice Chairman and members of the board. Each year, staff, along with HUB, Aetna, and our county attorneys review and update the health and dental summary plan description and bring it to the risk pool board for review and recommendation for Commissioner's Court. Several of the changes made involved clarification of an already existing procedure, but some involve changes to the plan. I would like to highlight those changes for the board. First, I will review the changes within the medical summary plan description. Throughout the SPD document, we reviewed and revised language to ensure the plan is in full compliance with the healthcare reform. This included revising the effective date to reflect January 1 of 2023. Throughout the SPD document, we reviewed and revised language stating Aetna's administrative responsibilities. Also, we revised and or added language to clarify the enrollment period for Medicare coverage for retiree and or their dependents. This includes the retiree enrolling in Medicare Part A and B in order to be eligible for the county's Medicare Advantage program. We also added language to identify where members are able to locate provider network information on the member site. Next, language was added to clarify continuity of care. Continuity of care includes a member being able to continue services with their provider up to 90 days of when the provider or facility ceased to be in network. Moreover, language was revised and or added to clarify emergency and urgent care. With this, a definition was added for emergency services and removed the definition of emergency care. In addition, we have added language under medically necessary to medically necessity section.
I'm sorry, can I interrupt you for a second? As you're going through the changes, can you dictate what page you're on? I'm trying to follow.
Sorry about that.
That would help.
Yes. Give me a second, sorry.
I'm scrolling through I'm trying to keep up with you.
Page 6 of 140.
Give me a moment so I open it on my end.
Okay, sorry about that.
It's okay.
Page 6 of 140, bottom left corner.
140. That's page 6 of 140.
She was on page 16 last, and I was going through this phone along with her. She went fast.
She talks fast.
We do. There's nothing wrong with that.
Sorry, it's going a little slow.
Emergency services is on page 18. And there was a big deletion there.
Okay.
She's scrolling. She's gonna go to page by page. She's simply scrolling.
Yo, slides are done.
So it doesn't update.
Okay. So for the dates and for the administrative responsibilities, those will be throughout the document. For the other ones, such as the Medicare, this will be on page 9. So the Medicare coverage for retiree and or their dependents, which includes the retiree enrolling in Medicare Part A and B. In order for them to be in the Medicare Advantage program, this will be on page 9. Okay. Now, in order for them to be able to find their providers on the member website, this will be on page 12. For continuity of care, where it specifies if a provider or facility cease to be in network and the member can continue services with them up to 90 days. This will be on page 13. For the emergency services and urgent care language that was revised, this will be on page 18 and partial 19.
So can you expand a little bit on why you made that change in regards to the definitions?
Yes, Joanna, I'll have Randy expand on that. Correct me if I'm wrong, it's regarding due to the No Surprise Act.
Okay.
Which one?
The emergency services and removing emergency care.
Oh, so those changes are made in conjunction with the introduction of the No Surprises Act.
Okay.
I don't know what that is.
No surprises. So we had a training a while last year. That's the new act that removes you from being balance billed if you go to an emergency room or you're on an air ambulance flight and the carrier pays a reasonable charge and the provider bills an unreasonable charge. So now there's a formal dispute process that either party can initiate that eventually goes to an arbitrator who makes a decision and says, you have to live by this. So, but in that decision, it also prohibits them from balance billing or anything what the provider says. So in essence, while it sounds, it is good for the member, no more surprise bills when you thought you were in network. But for the plan, when the arbitrator says pay, then we have to pay. So they may say, yes, you really should pay $250,000 for that air ambulance ride. And if they say that, then the plan would have to pay.
Thank you. Thank you for that.
Thank you, Randy.
Sure.
So that leads to the lastly, which Randy mentioned, voluntary and involuntary services section has been added to reflect the No Surprises Act provisions. And this was additionally added into page 49 as well.
Thank you.
Okay, sorry. I'll make sure I give you the right page.
Yes.
Before I continue to the changes on the dental summary plan description, does the board have any questions regarding the changes on the medical SPD? Okay, so moving on to the dental summary plan description, we actually only had one highlight on this one, which was updating the document to the effective date of 1/1/23. Everything else remained the same. And staff is requesting for the RISPO board to recommend the Commissioners Court to approve the restatement and changes to the health and dental summary plan description for plan year 23, contingent upon final review from Edna and our legal team, of course.
Okay. Is there a motion to approve the restatement and potential changes to the health and dental summary plan description as presented?
Second, thank you for being patient.
Oh, of course.
Trustee Asensio?
Aye.
Trustee Van Hoot?
Aye.
Trustee Hurtado?
Aye.
Vice Chair Salcido?
Aye.
Chair Quilty is absent, motion carries. Regular agenda item number 10, discuss and take appropriate action regarding the COVID-19 public health emergency coverage extension.
Thank you, Claudia. Members of the board, good afternoon. Now it's my turn to talk. So the item before you is a notice that we recently received from Aetna, letting us know that on January 30th, 2023, the federal government announced the 2 national emergencies addressing COVID-19, which is the public health emergency, and the national emergency would end on May 11th, 2023. And starting on May 12th, the health plans and group plan sponsors will no longer be subject to federal requirements for coverage of COVID-19 testing, vaccinations, and treatments. Based on the federal requirements, the RISPO board approved changes to the medical plan, which included covering these costs at 100%. This is back in 2020. Based on the announcement ending these requirements, the RISPO board, due to the medical plan being self-funded, can end the changes immediately or can elect to extend the coverage through the end of 2023. So before you is the notice, and it's also listing the what the coverages are going to change. So if you, Adam, if you can go on to the second page. On the second page, you'll see during the emergency on the left column, and then what that coverage starting May 12th would look like. So the only major changes are the COVID testing, the home test, and the COVID test done at a clinic or at a lab. Those will no longer be subject to being paid at 100%. It would be based on the employee's plan, their co-payment or co-insurance or deductible. And the other is the COBRA. They're extending the COBRA deadline until July 10th. Or again, of course, the board can decide to extend that coverage of allowing the deadline to be extended until the end of the year. I hope that makes sense. So that's the major changes that is happening with regards to the medical plan. So while this item was being brought before the board, staff asked Aetna to extend the coverage until the end of 2023 with the ability to revoke it if the board decides not to extend the coverage. Our request to extend the coverage is based on the direction the RISPO board gave back in March of 2020, which included waiving any costs to the member associated with COVID testing or vaccination. A review of the expenses associated with the federal emergency requirements indicates the plan spent over $800,000, as you saw in the at the end of the year report, for COVID tests. This is specifically on COVID tests. If the board chooses to end coverage effective as of May 12th or May 11th, employees will have to pick up the cost of the COVID test moving forward. But if the board chooses to end coverage at the end of 2023, the plan will continue to pay this cost until the end of the year. We've identified that other entities show a mixture of covering or ending the coverage from May 12th. And so staff is recommending to continue coverage of these emergency items until the end of 2023, in part so we can communicate this change more efficiently to our members during the open enrollment sessions. Does the board have any questions or direction what you want us to do?
I think from my perspective, I don't like the idea of retroactively applying a policy change. If currently it's only been a week, but it's been a week and we might have employees who fall under the category of participating in a lab test. If we make it effective back to the 12th or the 11th, we might have some employees who are not informed that their lab test will no longer be covered. So we have the kind of thought to allow for the extension to the end of the year.
I do as well. Yeah. It's only 6 months away. Why penalize the employee again? So it is very few. I would think that it's just a very low number. But they have to know that after December, that cost will be theirs.
Yes. So the motion would be to accept the continuation until the end of the year.
Staff recommendation.
Is there a motion to extend the COVID-19 public health emergency coverage through December 31st, 2023?
I'll move that the extension continue to the end of 2023.
Second.
Thank you. Trustee Asensio?
Aye.
Trustee Banu?
Aye.
Trustee Hurtado?
Aye.
Vice Chair Salcido?
Aye.
Chair Pulte is absent. Motion carries. Regular agenda item number 11. Discuss and take appropriate action regarding regular part-time employee eligibility for the medical plan.
Thank you, Claudia. Okay, so this next item, last year, as you may recall, as part of the plan design process and our presentation to the board, staff brought this item for the board's consideration, which involved changing the plan eligibility to include part-time employees. During that time, the board did not support extending the coverage to part-time employees, primarily due to the increased risk and the level of our reserves during that time. This benefit was brought up again this year during our budget presentations by a member of our Commissioners Court during the discussion with County Administration. However, because our fund is now at a healthy level, projections for next year also look good, and there seems to be a significant interest by the court to add this benefit. So staff is bringing this item back to the board attention for consideration for implementation effective 1/1 of 2024.
Randy, would you know of any other entities in El Paso, governmental entities, school districts, or city or county that actually allow part-time employees to have?
For counties and cities, well, let's see, for counties typically no. Mm-hmm. For cities and school districts, sometimes yes.
In El Paso?
Yes, and the reason, I mean, they're not really, well, they're part-time, so like schools may have a lot of bus drivers or cafeteria workers that only work 20 hours or so per week. And so they're not hitting that 30-hour average, but they deem those employees to be eligible for benefits. So they're in their own special category. And for cities in the summer months, you have a lot of lifeguards come on board, and they may work part-time or full-time, et cetera. So some cities make special provisions for seasonal labor, which kind of falls in the part-time category.
And what have you seen based on cost? Is it going to, because part-time is not really a lot in there.
Usually there's not much participation by the part-timers because they're not making that much money. Mm-hmm. But then on the other hand, like in the schools, there are people that take a job that only has 20 hours a week for the sole purpose of getting benefits. So it's not they're working for money, they might be working for benefits. So that concept by design promotes adverse selection. other words, I'm gonna go to work because I want the benefits, so I'm not really working for the money.
So how many eligible employees are we talking about?
We are looking at 53 part-time employees on any given year. And we don't have a high turnover on those part-time employees positions. Now, they would be paying the same rate as a full-time regular employee, so it's not going to be a different premium. So like Randy said, it's a small pool and we don't expect a lot of part-time employees joining, but it could potentially have, because we'll announce, as part of our recruitment, we're offering benefits to part-time employees, so that could add an unwanted risk that would join just to join the medical plan.
Randy, what is your recommendation based on how the other plans are doing, or the other entities?
Well, I would say, and I understand the rationale behind cities and schools and wanting to do that. So I think if there's a need for it, then that's, I would just call it the cost of doing business. But historically, part-time employee, and so that's what happened with the Affordable Care Act. Anybody working over 30 hours or more per week had to be provided benefits. And then a lot of employers changed their work schedule to keep them just under 30. So on the employer side, you typically try to minimize adverse selection opportunities.
Have we had employees, part-time employees, ask that if they can purchase health plan?
This is more on a significant interest from the court wanting to offer that to their part-time employees.
Oh, that's different.
Could we do an employee survey?
We could.
Specifically.
Okay. Little survey monkey.
Yeah.
See where we land.
We could do a survey to see.
Would you?
Their,
if it was offered, would you buy it? And put the rates in there so they know what kind of money we're looking at?
Impact.
Yeah, and then it's 53 people. But yeah, part of the young girls, and then they're going to have babies. They go to the NICU for 53 days. It's not lost 300,000. Don't talk about older people. With autoimmune diseases.
With this one, we do have time because it's not, we're proposing it being effective 1/1 of 2024. So we still have time to do that survey and we can bring that information back. So if you'd like, we can postpone this item until we obtain that results from the survey, provide that to the board, and at that time seek direction. Yeah,
I think so.
Okay.
Do we need to make a motion to postpone?
Yes, I believe we do.
To table it?
To postpone it for the next meeting.
Is there a motion to postpone item 11 to the next meeting?
Make a motion.
Second.
Trustee Asensio,
Aye.
Trustee Van Hook,
Aye.
Trustee Hurtado,
Aye.
Vice Chair Salcido,
Aye.
Chair Quilty absent, motion carries. Regular agenda item number 12. Discuss and take appropriate action on the retiree medical plan eligibility for employee dependents on the county's medical plan when an active employee on the county's medical plan passes away and is eligible for retirement through the county's retirement system at the time of their death.
Thank you, Claudia. Members of the board, staff received a new benefit eligibility request from the county administration office, which has also gained support by some individual commissioners. Currently, the county offers medical and dental benefits to active employees and to retirees and their dependents. However, should an employee who is eligible to retire passes away before they retire, their dependents who were on the medical plan only have the option to continue medical coverage through COBRA for up to, is it 18 months or is it 36 because of the death?
36 for the death.
So it would be 36 due to the death of an active employee. Whereas dependents of retirees can remain on the plan should the retiree pass away. So if they were already on the retiree medical plan and the retiree passes, then the dependent can continue. Our preliminary review after consultation with our consultants, hub, and their compliance team indicates the county can extend this benefit eligibility if it if the board desires. Over the last 5 years, the county has had 17 employees who have passed away. And of those, 12 were on our medical plan, and of those, 6 had dependents. So these 17 employees were eligible to retire, but they passed away before retirement. The request is to authorize surviving dependents of active employees since January 1 of 2017 to become eligible for medical plan benefits similar to surviving dependents for retirees, effective July 1st, 2023. So basically, we would open the eligibility for those who would fall in this category, of course, if the board approves. We would contact those who would have been eligible since 2017, those dependents, but they're effective for their medical plan won't be until July 1st, if that makes sense. So they would have 30 days from July 1st to enroll if they're interested. And we're talking about only 6 individuals who we've identified that were on the dependent category.
Is there a reason why this is going back to 2017 specifically?
There's no particular reason, but because we sought the data back for 5 years to see how many, and because we identified that there are individuals who would have been eligible, that's why they're asking us to look at that eligibility from 2017.
So again, Brandon, like, what is the trend, or what is the norm?
I don't know of anybody else who has invoked such a rule, but I understand it. So from let's say that the employee didn't pass away and they retired, then the risk is already on the plan and they would stay on the plan. When an employee retires and they're covered under the self-funded plan, the monthly contribution jumps dramatically because retiree coverage is pretty much adversely selected and it's older people. So it's not as if they would be, I guess, if you're going to have the risk on the plan anyhow, why not charge extra for it, which you would be able to do as opposed to when they're covered under COBRA. And then the county also contributes a significantly larger amount for the retiree coverage. They split the cost with the retirees on about a 50-50 basis. And I was going to look up some of those rates just to tell you.
It was 60.
Pardon?
It's 60.
$60?
No, 60%. The county
60%.
contributes 60% of the premium.
Could this be considered almost like a death benefit eligibility?
Yes,
Basically.
essentially, because the individual would have been eligible to
Right.
retire, but unfortunately they passed away as an active employee. That is how this would be allowable, because they're already on the plan. So we did receive this request last week. So we're still analyzing the impacts. We're still, of course, having our legal team review to make sure that there's nothing that would be impactful. We are looking at the risk, but like Randy mentioned, the risk, we already have the risk. It would just be for a longer period of time.
Can we wait till we get legal recommendation in order to? Yes.
So
They're reviewing it, so it's like.
Evan Ugas, Assistant County Attorney. So the specific legal question that we're looking at is really whether the benefit would be prohibited under the Texas Constitution. And really the provision that we're looking at is the prohibition against the gifting of public funds for a private party. And so the law basically provides that the only instance that you can retroactively apply that benefit is if the employee was entitled to it by law or by policy. But
We have a policy.
right, but that really ties into the compensation aspect. So now we're addressing a separate question as well versus, well, this benefit is not going to be retroactively applied and be paid for those past expenses that they may have prospectively, right? So now we're just looking at a very narrow question as far as just the benefit itself, which is not really any monetary amount that is being applied to it. It's just a matter of this is a benefit that's going to be open to certain individuals dating back to 2017, but those costs are not going to be paid, obviously, that far back. It's moving forward. So now I'm really just looking at whether that non-monetary amount or that non-compensatory benefit really is considered compensation for purposes of that prohibition under the Constitution. Does that make sense? And so what I have to look at, and I actually did look at it this morning, so tentatively, it doesn't seem like that benefit is really considered compensation or wages for IRS purposes. And that's really our guidance, because from the state purposes, you don't really have a definition as far as compensation is concerned. So it seems more so than anything that we're okay from a legal perspective, because it would not be considered compensation. So therefore, we're not gifting those public funds for private purposes. But I just want to confirm for you all, just to make sure.
And why 2017? What if somebody comes from 2014 and say, well, my dad died, we didn't get the same.
I'm in agreement. I think it's a very noble idea, and I'm in favor of it, but not retroactively. I think it's something that needs to be applied for future occurrences. And I understand that there might be employees. Yes, exactly. There's employees who might fall in that situation, or if they're survivors. But
if I'm not mistaken, and correct me if I'm wrong, but Anissa, that's my understanding, that it's the court's really direction as far as wanting to look at that time frame. So that's where the 2017 came from.
My understanding so far is it's not a benefit that's paid.
Correct.
It's from inception of the plan that's offered. It's basically an eligibility to be able to come into the plan, back into the plan, if they can afford it.
Correct.
And that's the biggest deterrent. The part about compensatory to private party, currently, if someone passes away and they receive retirement, where do the retirement funds come from?
Same amount of pool, the county fund is self-funded as well.
So therefore, the beneficiaries of a retirement, a deceased retiree is currently receiving monies from the county to a private party.
Not at this time, right? So that's where we're...
Because of the death benefits.
Right, so it's separate, right? Moving forward is what we're looking at as far as, actually paying those costs. And actually the county providing that contribution, which is the 60%.
Right.
However, as far as who the potential pool of individuals that could potentially, benefit from that would go back to 2017. And so because the county's not paying for, their health costs, is not contributing, any kind of premiums, there is no monetary amount that's actually being provided, even though it's being expanded that far. And so that's where the assessment really comes down to, well, if we are expanding this coverage and giving this benefit to the employees, is that considered compensation for purposes of, wages, or compensation for purposes of gifting those public funds? And so from preliminary, like Berenice explained, and really we got this legal question yesterday late afternoon, so I just really briefly did some research this morning. And from what I found thus far, it doesn't seem like it would be considered compensation. So because it's not considered compensation, just the opening of expanding that benefit going back to 2017, then we would more than likely be able to proceed forward without any violations to that prohibition against the gifting of public funds. But again, because the costs that are going to be applied are going to be prospectively.
I see what you're saying, and the choice of words is what's the confusing part. Retroactive benefit. I don't view it as a retroactive benefit. It's a retroactive eligibility versus a benefit.
I would agree with you.
Okay. That way, it's not there's no commitment to funds. That's retroactive. It's only commitment to opportunity for eligibility from this date forward if you choose to enroll, in which case you pay a certain part and the county pays a certain part. Okay, the 60%, right? And you said how many were there? 6, 8?
6.
6 individuals. Are they in the position to enroll and come up with the higher rates versus the live people that are working? You know what I mean? I think it's trying to take care of the families of employees up to a point. I don't think it's going to impact the county because not very many of them are going to be able to pay for it. So, but I don't know if you want to look at that as a gesture of support for the employees having worked in DCs versus let's look at it realistically. No one's going to be able to support it, those funds. So do we want to put them through that?
And some of these individuals, these dependents, if they were spouses, they might be already on Medicare eligibility. If so, they wouldn't join the county's medical plan. It would be the Medicare Advantage plan with Aetna. So that would be a separate cost. But it wouldn't interfere, right? But it would just open that ability for them to join that Medicare Advantage plan. So we would, if the individual, let's say they're not Medicare eligible, they're maybe 2 years away from that, then we would just keep them on the medical plan until they become Medicare eligible. So we would have the risk until they're Medicare eligible. If, of course, if there were a spouse, I'm not sure if a lot of them had their child as part of their medical plan, because if they did, maybe the child already has a job that they have their own health insurance, which is a lot less expensive than the retiree plan. So there's maybe that case too.
And then children, if there are children under the plan, they age out of the plan at age 26, just like any other active employee. So the long-term risk is going to be spouses or qualified +1 dependents.
It seems like, to me, precedence is usually only for active employees, part-time or full-time. And cost-wise, you have to look at it realistically. It's a gesture, if anything, but in reality, it's like saying, you're working for me, you can buy this Coke for $2. You're no longer working for me, we'll give you the opportunity to buy this Coke for $3. It almost sounds like a slap in the face. I was just going to use that sentence. So do we want to go that route? And explain it in those type of terms to the commissioners that are interested in it. Not to say they're wrong. I can see myself where they're coming from, but is it practical for the people themselves? For the county, I don't think there's going to be much of a risk involved at all.
If I could add one thing. So there is local government code that applies to death of a peace officer in the line of duty. And so you have a lot of peace officers covered under the plan right now. And if a peace officer dies in the line of duty, their dependents are eligible to stay on the plan regardless of whether they're eligible for retirement or not. So I think maybe there's some thought process, well, if we do it for them, can we do it for these guys too? I think maybe that's part of the thought process.
Okay, I definitely see that. the risks involved, a peace officer and someone else is not the same.
Yeah.
So the benefits, to some degree, should be the same, but maximum not. Having been a peace officer myself, yeah, I understand that very much. Just curious. Good, something good to gather more information on.
So staff's requesting contingent upon final review of our legal team, or if there's contingent on any significant impact or legal issues, staff is seeking the Municipal Board's approval to add this eligibility request to the draft summary plan description that we went over today, or your direction of whether or not you support this.
I would also, as stated before for the previous item, any chance of contacting those individuals and say, if this were available, would you be able to pay this? Because if they can't, it's on you.
Or they don't want to.
Yeah.
They kind.
We could. I know that the court wants to move quickly on this. It wants to make it available July 1st. So if we'd like, we can seek that response, but we would call a special meeting in June for the board's discussion on this particular item.
That sounds, yeah, because what if the six say no? I already have mine here. What's it going to cost? And well, it's expensive. Where you offered it to me at that price?
Okay.
And
So,
that way the court will be, they'll be like, oh, well, maybe we didn't think about that.
okay.
Now, like I said before, I feel we're here to not only be fiscally responsible for the expenditures of the county, but also take care of the people themselves. So it's a two-sided sword that we need to swing.
Okay. So we'll do this. We'll reach out to the part-timers and for this one as well, and we'll bring you those two items for consideration. We'll do a special meeting in June. That way we have enough time before presenting it to the court.
That would be fair to them and to the commissioners and to us. As long as there's no big accidents out.
Okay, so at this point in time would be motion to postpone?
Yes.
Is there a motion to postpone item number 12?
Motion. Second.
Thank you. Trustee Asensio?
Aye.
Thank you. Trustee Van Hook?
Aye.
Trustee Hurtado?
Aye.
Vice Chair Salcido?
Aye.
Chair Quilty is absent. Motion carries. Regular agenda item number 13. Discuss and take appropriate action to accept the bi-monthly report from Club International Benefits Consulting.
Good afternoon. I'm Randy Woodrow from Hub International. Patrick Avila is here. And today Patrick is going to deliver the bi-monthly report for us quickly.
Motion to adjourn. That was quick.
All right, good afternoon, Vice Chair, members of the board. My name is Patrick Avila of Hub International. I'm happy to be here to share the health plan update. You heard a lot of good information from Aetna regarding the 2022 plan year, as well as the county personnel. So let's talk about what it looks like this year, right? If we want to skip over to the page, inflation trend and auditor report. Number 3, yes. Okay. Before we get started though, please note that the information that's going to be presented to you today is the data that we have received through the month of March. Next meeting we'll have the information through the month of April. You'll see here that the medical inflation rate for gross paid claims is currently a downward trend of 39.2%. That's really good, right? Mm-hmm. Kind of aligned with what's been happening in 2022, and so that's good news for the county health plan. The pharmacy inflation rate is, however, currently up almost at 18%. We typically like to see this at 11%. However, that's not unique to the county. It really is, everywhere. It's happening everywhere where pharmacy inflation is up, especially with specialty drugs, which Aetna is reporting it's accounting for 44% of the spend. The dental inflation rate is also up slightly, nothing to be concerned about. We typically like to see a 3% number, but 5% isn't bad at all. Moving along, we have the inflation trends and auditor report. Basically the same information illustrated in a different way. The only thing that you don't see, a few things that you see in this one that you didn't see in the other one, is the total spend for medical, dental, and prescription, still showing at a negative 26%. Even though prescription is significantly higher, right? But overall, we're still doing well. Some things to note is that in the month of April, revenues exceeded expenses by $774,000. For fiscal year to date, revenues have exceeded expenses by $4.2 million. This is with your fiscal year starting October 1. And the actual reported fund balance as of April 30th, 2023 is $8.7 million. Moving along, claims and enrollment experience. The annual claims comparison reflects total medical and pharmacy costs. As you're aware, we do track any claim that exceeds $50,000 to ensure that we are monitoring anything that might be in the pipeline that could cost the plan a lot more than that. As of now, you have 5 claimants that have exceeded the $50,000 threshold, but we don't anticipate it going more than that. In 2023, so far you have no claimants that have exceeded the $300,000 stop loss deductible. Just to reiterate, in 2022, 10 claimants met the individual specific limit of $300,000. Their expected recovery from Aetna is anticipated to be $3 million. The year-to-date medical discount rate is looking good. It's exceeding, we're at 71.7%. We'll look at that in our dashboards page as well, which is the following page here. This is what we call our dashboards report, your claims experience. And what this does, you're familiar with it, you've seen it several times. It really does go dissect everything year by year, including 2023, by relation, by plan, by group. It kind of tells you everything, where the money is being spent, how much members are paying. But really, the number that we really want to focus on is, once again, that group average medical network savings. And we're sitting at 71.7%. Again, really good for the health for the county. The next graph, we see claims experience broken down by dental, medical, and prescription, monthly gross claims costs. Again, still looking good. We're up a little bit from January and February, but nothing to be concerned about based on the programs and resources that Aetna has been providing the county. In terms of the claims experience, once again, we're going to talk about the claims that we track that exceed $50,000. In the month of March, you can see that none of these exceeded the stop loss deductible. We also like to illustrate what diagnosis it is and primary provider. You'll note that there are 3 providers in the month of March that are not within El Paso, and that can be for a number of reasons, right? Dependents seeking care elsewhere, or just going for treatment in different locations. But we do like to track those, and we'll definitely monitor those if something comes up that doesn't look right. The next slide illustrates your claims experience. Once again, we do track additional claims, especially those that exceed $150,000, to ensure that we aren't expecting anything else moving forward. Remember that the individual stop loss deductible is $300,000, and you'll see here that in 2023 year to date, you have not had any members or claimants that have exceeded the $300,000 threshold. One came close, however, it did not exceed, and so we're looking really good at this point in terms of high cost claims.
Too bad Aetna's not here to
And the following slide is your enrollment experience overall. And so You'll notice that the green line is for 2023. We're down a little bit overall from 2021, but up from 2022. And so this just kind of gives us an idea, a picture of where you're at in the month of March for enrollment. But then we have an enrollment experience illustrated by plan. This kind of is illustrated differently. The 2023 starts off on the far left, right? And so you have 1,300 employees in your core plan and 1,100 employees in your consumer-driven health plan. The average cost per member per month for pharmacy for 2023 as of March is $169.23, and for the medical is $270.65. The following slide illustrates the average cost per member per month by plan in a 12-month moving average. The green line, if you recall, we discontinued the buy plan, so therefore we're no longer tracking that, but we are still tracking the consumer-driven health plan and the core plan. You'll see that it is going on a downward trend. Specifically for the consumer-driven health plan, we're looking at $326 per member per month and $548 for the core plan. The following slide breaks it down. Average costs, 12-month per member per month moving average claim costs. For medical, you'll see the green line. It is going down, as we've mentioned previously, but you'll notice that in pharmacy, it is up there, right? And again, we can attribute that to the specialty spend that is currently being, the members are currently utilizing. And then we have the average cost per member per month for claims costs. In 2023, it has gone down significantly from 2022. Again, good news for the county as the health plan is doing very well. The average cost per member per month regarding dental, again, as we mentioned earlier, it is at 5%, which is a little bit higher than we'd like to see, but really if you dissect it and you calculate it, it really equates to about 20 cents per member. That's gone up. So it's nothing bad, nothing to be concerned about, still looking good. The forecast review, just for your information, we are reverting to only using claims data provided through Aetna's standard reporting. During the surge in the claims in the post-pandemic era, weekly reports from the auditor were being used to incorporate the most recent expense data. Reverting to one consistent data stream of information will be used moving forward. And here we have the forecast. Lots of information here, but really the one thing that we'd like you to focus on is that negative 2792 number there. Again, more good news for the county, assuming that the claims expenses will continue to come in, right, at 24 million roughly, and assuming that the inflation rate will be at a 10%, and having paid back having done the repayment to the county general fund of $3 million, we're still standing at an ending balance at the end of this year at $12 million, right? Which is, we're at a surplus. Assuming that the claims expenses, assuming all the numbers for 2024, you're sitting at the end of the year in 2024 at $17 million, again at a surplus of $10 million. So doing really good, now and moving forward, and we anticipate it continuing to do well.
How much do we owe the county? Are we're done?
Another $3 million.
Oh, another 3?
Which I think you'll be able to pay back this year easily.
Good.
Once again, here we have the County of Paso self-funded plan contribution versus net expenses. That shaded blue area is your contributions, which shows upwards, and your net expenses is showing a downward trend again. So again, just reiterating that it's looking really good in terms of expenses versus contributions. And then this just illustrates this in a 6-month moving average. All right, we can skip over to the Aetna CVS Pharmacy reports. And so lots of information and numbers to absorb here. However, something to focus on is the number of employees prior to current. So prior, we had 2,472 employees enrolled, and currently we have 2,496 employees enrolled. Number of utilizing members, however, is less than, is down, right, from the prior year. Total pharmacy spend is 1.6 million, and we're currently at $2 million. So if number of utilizers are down, why are we seeing such a high cost in pharmacy, right? And it's really just the dollar amount, right? What people are getting in terms of specialty drugs. And then that kind of segues over to the next page here, where you'll notice that down at the bottom right corner, the number of utilizing members, that very last number is 35, and those 35 utilizing members are accounting for $1 million in claims expense, right? Paid amount is almost 900,000. So we're just seeing a lot more members, a lot more money being spent on pharmacy, right? Although there's less utilizers. All right. The Aetna pharmacy reports. This is the drug claims as they relate to a diagnosis overall. And so the top 4 numbers don't typically change, but what we want you to take note of is the number of claims submitted. 764 claims, 558 for, 764 for anti-diabetic. And like I said, those numbers don't really change. Oh, I'm sorry, it's the following page. There we go. And then we get more specific when it comes to, on the following page, we get more specific when it comes to the drugs ranked by claim count. You'll notice that the number of claims is listed there, and you'll see that metformin, which is a diabetes medication, is coming up. But if you go a little further down on the list, you'll see that Ozempic, the hot topic that we're all talking about here, and that again, that's not just the county, but industry-wide, Ozempic is creeping up. And I believe Aetna mentioned during their review that they're going to start implementing those smart edits to ensure that members aren't receiving a medication that they don't need, right? And rather maybe steering them to in a different direction. The Aetna pharmacy reports top drugs ranked by paid amount. Once again, now we see Ozempic as the #1 top drug. And there's things happening right now. There's things that are going to be implemented by Aetna and the county to ensure that we mitigate that. You'll see also that the medications in blue are specialty drugs, and then those in white are non-specialty. Top paid specialty drugs as percent of total year to date is 37.4%.
Patients need those drugs.
All right, the following Prudent RX report is for 2023. So, Prudent RX was implemented as a cost savings program for the county. Year to date, the net savings that we've seen is $116,000. Remember that this savings plan is only on the core plan. I believe very soon it'll be implemented on the consumer-driven health plan, correct? Yeah. So we've been able to implement that in the consumer-driven health plan. And when does that?
The board approved the amendment to the Aetna agreement to include that Prudent RX to the CDHP plan during the March meeting, I believe. And then the court just approved it this past Monday, or the previous Monday, and so they should be implementing it here fairly quickly. So we're hoping to have a report just like this that's reflective also of the CDHP plan members.
And you'll start seeing more savings. And lastly, the Prudent RX savings report year to date for 2022 is showing that top specialty spend is at $2.1 million, And thus far, the net savings that the county has received is $260,000. Now, this in face value, right, looks great, but this just means that more employees are consuming more specialty drugs, right, which is more costly. But so the goal is for that to not happen. However, this is just proving that the implementation of Prudent RX is working regardless of what members are doing. And to date, you've already exceeded what happened last year of $260,000 in savings.
On that RX, on the specialty drugs, can you pull the data where it shows how old they are? Because that way you know that if you're 60, you're going to retire pretty soon.
Oh, the
And they'll
age
come
of
off.
the.
That's the only way they're going to get rid of us, is you retire. Because other than that, they're going to keep on using it.
Yes, they can do that. You can see too, in that second column from the right, there's only 33, and this is all of 2022. So there are only 33 people that were impacted by the plan to generate that much savings. That's just magnifies the cost of that. So then 2022, we have 260,000 in savings. First quarter 23, we're at 116 already. And that number will probably double once we add the consumer-driven health people to the equation. So, like I was telling Patrick, we would like to see this report come by and show us that there's no savings, which would mean that there's no drugs being used.
But since they are being used, it's good to see that there is some savings and that we're not paying the highest cost.
And that concludes the presentation. We're happy to entertain any additional questions you might have.
Yeah, any questions? Hey, thank you, Patrick and Randy. Is there an item to accept the bi-monthly report from Hub International Benefit Consulting? There goes. I'll second.
Trustee Asensio?
Aye.
Trustee Van Hook?
Aye.
Trustee Hurtado?
Aye.
Vice Chair Salcido?
Aye.
Chair Pulte is absent, motion carries. Regular agenda item number 14. Discuss and take appropriate action to accept the Human Resources bi-monthly report to the School Board.
Thank you, Claudia. Just two items very quickly, okay? First, I want to go ahead and introduce to you two new county attorney team members to the HR team. They may not be new to the county, but they are new to our HR team. So wanted to take this opportunity to introduce them. We have Kevin McCurry, and we also have Eric Bauer. Don't be shy, you can come over.
He's scared.
So if you guys wanted to go ahead and introduce yourself.
Sure. I'm not actually new. I'm actually recycled. Like Randy could tell you, he's like, oh, I remember that guy. Yeah. So I'm the supervisor in the county attorney's office over the unit that, among other things, advises human resources. And so we wanted to take a minute to let you know that Evid will be leaving you. She's headed out to JPD and will be letting go of the risk management side of her work portfolio. And the ever talkative Eric Bauer will be taking over her role with you all. So you'll be seeing him quite a bit in the coming months.
Welcome.
Thank you.
Don't be scared.
Thank you, Kevin.
Yep.
The next item is I wanted to take this opportunity to congratulate both Trustee Asensio and Trustee Van Hook for their recent reappointment to the board. I'm glad to have you on board for an additional term and looking forward to working with you for this next term as well. So congratulations.
Thank you. Congratulations.
And that was it. I promised 2 items.
Thank you, Betty. Is there a motion to accept the Human Resources bi-monthly report?
Motion.
I'll second.
Thank you. Trustee Asensio?
Aye.
Trustee Van Hook?
Aye.
Trustee Hurtado?
Aye.
Vice Chair Salcido?
Aye.
Chair Pulte is absent, motion carries.
Is there a motion to adjourn?
Motion.
I'll second.
Thank you. Trustee Asensio?
Aye.
Trustee Van Hook?
Aye.
Trustee Hurtado?
Aye.
Vice Chair Salcido?
Aye.
Chair Pulte is absent, motion carried. It is now It is now 3:51 p.m. The regular meeting of the Board of Trustees for the County of El Paso's School Board is now adjourned. Thank you, everyone.